Welcome to the Compliance plus Ethics equals Integrity podcast, featuring BerryDunn Healthcare Practice Group professionals and expert guests discussing their insights into contemporary as well as perennial healthcare regulatory, revenue integrity, general compliance, and risk management topics. My name is Robyn Hoffmann. I'm a senior manager in BerryDunn's Healthcare Practice Group. I am very pleased and honored to be joined for this podcast by two colleagues from BerryDunn's Healthcare Practice Group, Senior Manager Cheryl Krusch and Manager Natalie Laaman. The title of our podcast is Telemedicine in 2023. The concept for this podcast came from some of our recent internal conversations about the state of telemedicine in calendar year 2023 and the uptick in audits that are being conducted by governmental payers such as Medicare, Medicare Advantage, and state Medicaid programs, as well as commercial health plans. But before we get into our discussion today, a quick disclaimer. The content we discuss in this podcast is based on our professional experience advising healthcare providers, facilities, and other organizations that engage BerryDunn for compliance and other services. While we may reference specific government programs, Medicare and Medicaid policies, and regulatory guidance, we do not speak for any government agency or contractor, nor do we have the authority to do so. Nothing in this podcast should be considered legal advice. Anyone seeking legal advice on the subjects we discuss should consult their own attorney. And now it's my pleasure to introduce my two colleagues. I would like to ask Cheryl Krusch to share with us some information about your extensive professional background and the types of services that you provide for BerryDunn's clients. Cheryl.
Thank you, Robyn, for asking me to participate. I'm happy to be here. I'm a licensed practical nurse in the state of Connecticut and have been for 35 plus years, worked in several settings, such as acute care facility, physician private practices, and skilled nursing facilities. I also hold several documentation and coding credentials, such as certified professional coder, professional medical auditor, ICD-CM certified trainer, to name a few. I've worked in several settings, including two large HMOs in the state of Connecticut, where I managed the prior auth department, the Connecticut State Medical Society, IPA, where I analyzed billing data of over 7,000 physicians in the network, providing documentation and coding support, as well as working in a large billing company in the state of Connecticut before joining BerryDunn. So at BerryDunn, I lead a team of coders and auditors here, as well as personally review clinical documentation to support codes that are billed and documentation to support medical necessity for encounters and procedures. I also focus on specificity and accuracy of ICD-10-CM codes, modifier assignment, and as well as providing recommendations for improvement. We work with attorneys when their clients are facing federal, state, and sometimes third-party payer audits. And we also have clients come to us proactively, which is our favorite client. So they are prepared if identified in an audit or being targeted in an audit.
Thank you so much, Cheryl. Your certifications truly dazzle me. Thank you so much. And I am pleased to welcome Natalie Laaman to talk with us today in the podcast. Natalie, might you please inform our listeners about the types of services that you offer to BerryDunn's clients and share some details about your own professional background?
Thanks for having me, Robyn. My entire career has been in compliance, specifically in revenue compliance. I'm certified in healthcare compliance through the HCCA. I'm a certified professional coder, and I have several other coding certifications, including outpatient coding and clinical documentation improvement. Before working for BerryDunn, I've worked in several healthcare systems in Connecticut and Massachusetts. Alongside Cheryl, I offer anything audit related, whether it's clinical documentation improvement, coding, billing. We help clients with their proactive audit needs, or we help validate their external audits. And we also help clients implement their own internal audit programs. So I'm excited to talk about telemedicine today.
Thanks so much, Natalie, and congratulations on the volume and breadth of certifications that you have in your background as well. So, Cheryl, when we were having that conversation recently about telemedicine as calendar year 2022 was coming to an end and 2023 was getting started, you talked with us a little bit about some of your observations about how these services are documented when you're conducting audits for clients. Can you share a little bit with our listeners about what you're seeing?
So thanks, Robyn. Like everything else, there's documentation requirements when billing telemedicine services. Specifically, the method that the telemedicine service was conducted, was it audio and video or just audio? Where was the provider and the patient located during the telemedicine service? And was the patient in a safe, secure setting and alone? Time should also be documented if required by the code set. And of course, the patient consent, which I'm going to let Natalie talk about. The remaining documentation requirements are the same as if they had been in person, face-to-face, such as evaluation and management services. I have to say the documentation in the clinical setting is getting better for the requirements for telemedicine, as compared to when we first started looking at them in 2020. They were horrible. So that's about what we see mostly.
Thanks so much, Cheryl. Absolutely. It feels like we've all come light years ahead over a 3-year period. Thanks so much. And you were mentioning that the talk about consent. That is a vital aspect for telemedicine visits. There has to be clear documentation that a patient has given their consent for this type of technology. So, Natalie, as you're conducting your audits, can you share with our listeners what you're seeing in terms of the robustness of the documentation of patient consent?
Sure. As Cheryl said, the documentation has improved over the past couple of years. And thankfully, the majority of encounters that we've reviewed recently have appropriate consent documented. Not all providers document consent the same way, and that is okay. Patient consent can be verbal or written. So some providers document that the patient has given verbal consent right in that encounter's note. Others provide a separate written consent that the patient signs and then is scanned into the medical record. The important part is that it's somewhere documented in the medical record. For Medicare, the consent is a condition of payment, so it has to be there for you to have to receive payment. All of the states that we've reviewed have the same standard, but we always recommend checking the individual state's regulation regarding patient consent.
Thanks. I think that's really a critical advice that you've just given, Natalie, in terms of state Medicaid is state Medicaid. In other words, it varies from state to state. It's different from Medicare requirements for telemedicine, to be sure. So I'm wondering, Natalie, as you're thinking about, literally last night went on my computer and saw that it looks as though the end of the public health emergency will be on May the 11th. I frantically checked this morning on the CMS website and on the Federal Register. I haven't seen an official ending date on either of those venues yet. But as we're coming to the end of the public health emergency, Are you seeing any increases in the number of audits that are taking place? And are there differences by payer type? In other words, are there differences in terms of volumes between the governmental payers versus the commercial health plans, Natalie?
So we haven't yet seen a significant increase in audits specifically for telemedicine, although there are several providers who are choosing to proactively audit, which we always recommend. This is very important because you'll get a mix of services and payers that are either provided face-to-face or using telehealth, whether they're billing Medicare, Medicaid, or they're commercial payers. By having us help with these audits, we're able to evaluate whether the providers are documenting properly for the service, because even though the service is performed using telehealth, documentation still needs to meet that CPT description. We're also able to help review to make sure the patient consent is there and make sure the coding is going out properly. You have the proper modifiers, time is documented. Everything that's required is there, and this helps providers be prepared if an external audit does come their way.
Absolutely. I think what both I've heard you and Cheryl say today is, to use an old adage my mother used to say, prevention is worth a pound of cure. In other words, if you can have an external auditor from a trusted advisor, such as BerryDunn, to offer guidance to your clinical practice about documentation, it is well worth that type of advice prior to having an external audit take place from a payer source. You know, as we were talking a couple of weeks ago about telemedicine, Natalie, one of the things that we were talking about was, are you seeing any differences by, excuse my air quotes, service line? In other words, are you seeing any differences in terms of volumes of audits that are taking place for behavioral health telemedicine visits versus medical telemedicine visits? Could you talk with us a little bit about that, Natalie?
Sure. So we've seen a lot of behavioral health external audits come through. They haven't been specific to telehealth, but behavioral health does seem to be a target. With that said, the OIG added several services to their work plan that are provided through telehealth. And they stated that there's going to be two phases of this work plan item. So the first phase, they're going to be looking at E&M codes, opioid use disorder, end-stage renal disease, and psychotherapy, all provided using telehealth. And the second phase includes the virtual check-in codes, remote patient monitoring, and annual wellness visits. And back in April in 2021, the OIG released an audit report that focused on telemedicine services, and it found that providers failed to document start and stop times and location. And the report did note that the providers never received formal training on how to properly document these services. So we often say, use these reports and learn from their mistakes. Audit, and understand where your risk is so you can do better.
And just to reinforce a point that you made, and I certainly heard you say this a couple of weeks ago when we were speaking with some providers in Rhode Island, is that it's really critical to document the actual start and stop time as opposed to saying 45 minutes, that is really a critical element. Did I hear that correctly, Natalie?
Yeah, that's correct, because some providers in their systems put the time in as the appointment time as 3 to 4 p.m., but we all know that hardly anyone runs on time. Services hardly ever start exactly at 3 o'clock. So what we are saying is put the start and stop time so it started at 3:06 p.m. and it ended at 3:55. And this time does matter because there are CPT codes such as behavioral health that go to the minute. So for behavioral health, you can't report a service less than 16 minutes. It's an odd number. And so the minutes really do matter here.
Thank you so much. That's really critical advice. So I'm just wondering, as we're wrapping up our conversation today, I would like to turn to both Cheryl and Natalie and ask each of you if you could offer our listeners one critical high priority recommendation for healthcare organizations as they assess their telemedicine services in 2023 and deal with any external audits. So I would turn first to you, Cheryl, if you could talk with us about that.
Sure. Thanks, Robyn. I think the biggest thing right now is we all have to keep our eye on the moving landscape of telemedicine. Prior to the pandemic, telemedicine was not highly utilized because of the cumbersome way in which we all needed to use it, meaning there was a list of regulations as long as my arm regarding providing telemedicine services. Then along came the pandemic, and telemedicine became basically the only way one could access care. Not to mention, I'm sure you all remember, because my head still hasn't stopped spinning. In 2020, there was a webinar, it seemed like weekly, one from Medicare, one from Medicaid. Do it this way, no, do it that way, add this modifier, no, don't use that modifier, use this one, and so on and so forth. And it was just crazy. So I'm wondering, or I'm assuming, that we're going to have a little bit of chaos as the PHE ends as well. So we all know that payers run behind a few years in their audits. So I think it's important also to retain the documentation of when the waivers ended and what they covered, because 2 to 3 years from now, you're not going to remember. And also have a plan in place outlining your practice's use of telemedicine post-public health emergency and the periodic auditing of your clinical documentation. So the Center for Connected Health Policy is the nation or national telehealth policy resource center and contains state-specific information on all things telehealth, including Medicare, Medicaid, FQHCs. They talk about things such as state requirements and parity laws. They talk about the codes that can be used by provider type. They also give you some rules on out-of-state providers. And then, of course, FQHCs and what modalities are allowed, eligible originating and distant sites, and a whole host of other information that's way too much for me to say right now. So I urge everybody to go out and check out the CCHP site, and you can find that at cchpca.org. It's a really good site.
That is a great resource, Cheryl. I totally agree. I am a visual person, so to see the maps that they produce so that you can take each of those issues and see a mapping to get a sense of, for your state jurisdiction, what are the rules in a great snapshot? Very, very helpful information. Natalie, I'm wondering if you could offer our listeners a really high priority recommendation. What would be on your list?
As we said, for anyone providing services using telehealth, we recommend performing an internal review to understand your risk level. We usually recommend taking a random sample of claims and review for proper documentation, coding, billing, look for the proper modifiers, and of course, patient consent. It's also important to make sure the providers who are rendering the service are eligible providers. So unfortunately, as we said, Medicare and Medicaid are not always the same. So it's always important to review your state's regulations.
Absolutely. And for those providers who span 2 jurisdictions, if they're dealing with 2 different state Medicaid agencies, it's really important that they check each of those states' rules around telemedicine or any requirements. I would like to thank you both so very much. Thank you for sharing your wealth of insight and recommendations with us, Cheryl and Natalie. We've reached the conclusion of today's very informative discussion about the state of telemedicine in 2023. On behalf of Cheryl Krusch, Natalie Laaman, and myself, Robyn Hoffmann, we thank you for listening to this episode of BerryDunn's Healthcare Insights Compliance plus Ethics equals Integrity podcast. We welcome our listeners' questions and feedback about the ideas and concepts that we discussed today, and we would really value your suggestions for topics that we should consider for future podcasts. Thank you so much.